All right, everyone. I promise we will have more time. We've got a really long networking lunch period. We've got an hour and 15 minutes. So if you could push the pause buttons on your conversations right now, pick those back up at lunchtime. I'd like to invite our panelists to come up to the stage. Thank you. Thank you so much. And I'm going to grab my seat up here. I promise I'm not going to do a whole lot of talking, but want to thank all of you again for being here. I want to thank our amazing panelists. And just to start us off, I know that there's a lot happening in the treatment space, so we're just going to hear some snippets of this work. As we kick things off, Rob mentioned earlier today some in kind of the report of the laundry list of things that the consortium's been working on over the last year. We do have MOUD, or opioid treatment, or opioid use disorder treatment gap landscape analysis that, thanks to our partners at the Colorado Evaluation Center, University of Colorado Evaluation Center, put together for us. It was a repeat of a landscape analysis that was done back in 2022. I've got just kind of the general findings here, as well as a QR code for you to link to that. It is on our website, housed on our treatment work group page. So you have to dig a little bit for it. But when you get copies of our slides today, you can also use the QR code to link to it that way. I don't want to have our panelists duck at the moment, but we can bring this back up if we need to. So check that out. Although we're going to be hearing a lot about some of the growth and some of the amazing things that have happened over the last year and things that are in the works, just want to always keep that idea of we still have lots of work to do to address disparities in our communities across the state. So with that, want to just kick things off, again, welcoming our partners up here, and I'll let them introduce a little bit about themselves, what they wanted to talk about today, and the opportunities that they are seeing and taking advantage of and even creating in the space of treatment in Colorado. So JK, I have your slides lined up first if you want to kick us off. Yeah, to go on.
Okay. Next slide. Thanks. So for the last year or so, the Stedman Group, that's my group, we're a small woman-owned consulting firm. Oh, and I'm JK. I'm a physician, person in long-term recovery. And we've been working with the consortium and with hospitals throughout Colorado on improving medication for opioid use disorder treatment in emergency departments, and then improving their referrals into the community after they've treated them, usually with Suboxone, buprenorphine. And so we got a late start this last year. So our project was only about 4 months, but we engaged 3 of the largest health systems in Colorado. This was mostly a convenience sample because we wanted to get the most facilities with the least effort. So we worked with Common Spirit, Intermountain, and Advent Health, and talked to them about their current protocols for MOUD administration. So good news. In fact, all of those hospitals, all of the large health systems have protocols and regularly treat people with buprenorphine in emergency departments. So really good news. I think 5 years ago, even that was not the case necessarily. And now most of them report that virtually 100% of people who come in withdrawal are screened for and treated with buprenorphine when they're eligible and when they want it. So that's really, really good news. The less good news is that referral back into the community, people following up after that induction, is still pretty low. I don't have an exact number, but I think it's around 30% of people follow up after an induction, which is a big opportunity because a lot of those people came in withdrawal after an overdose. And the fact that less than 3 out of 10 of them follow up in the community is really a missed opportunity. And HCPUF has recognized it as such. I know the follow-up data in the community is still lagging from the 1115 waiver, and that's something we'd all like to see improve. So some of the things that we did over the last few months is all of them recognize that their referrals, so they refer outside their system. Almost none of them have in-house medication treatment. Hospital systems don't generally do that, which is unfortunate, but they don't. And recognize that a lot of their referral lists were pretty how should I put it, dated, I guess, and sometimes limited. And to illustrate that for you, we had one ED medical director that this was like a big cringe moment for me. He said, I would never send anybody to OTP to get methadone after Suboxone because it's such a dangerous drug. And that just like blew my mind that a medical director would say that. And that's his experience, that he's seen a lot of people with QT prolongation and other fairly rare side effects of methadone treatment. But it was interesting to get that insight into why people refer the way they do, which is largely keeping them on Suboxone, which might not be the right drug for them. And I know there's a lot of OTP people here, and that you're probably cringing like far more than me at this. But it was a good example that there's still some education to be done. Angela is definitely cringing about this. Definitely education to be done to show people the breadth of options they have after an ED stay and after Suboxone induction, that like people can go out and get whatever drug works best for them, or they should be able to. And so we help folks with referral lists. Sometimes they were referring to like somebody they found on the internet who maybe prescribed buprenorphine once. And so we help them get people to places where they could do 24-hour inductions. There's a few of those, both OTP and then online options, and places where we believe they're going to get better follow-up. And then we help them with some like publicity. They had some newsletters and things like that. And so the good news is we're going to continue this next year, and we're going to expand it to more health systems. So we will probably be in touch with you if you're with a health system that we haven't worked with yet. And if you do work with a health system and you want help with buprenorphine treatment in the ED, or especially the follow-up part, we'd love to help you with that. Next slide. So our goal is to work with 10 more health systems. So instead of being with like big health systems that have 5, 6, 7 hospitals, we're going to work with some of the smaller ones that probably just have one hospital. And so that'll involve a lot more outreach, a lot greater diversity of rural frontier hospitals, critical access hospitals. And we can help with pretty much anything. So we've helped develop MOUD protocols, linkage to care. And one cool thing I wanted to highlight is that a lot of hospitals are improving their linkage through information technology. I think many, if not most, health systems have Epic, and a lot of them are picking up something called Link ED. And so this is a touch of a button referral to an external resource, whereas before that was like very the doctor was talking to them, or the nurse was like one-on-one handing them resources. This can actually task an outside organization like an OTP or OBOT with follow-up with a patient and hand off that information to them with the proper permission. So that's really promising, that there are not only people working on this, but also like technologies that are working to advance better referrals. And then the last thing I'll talk about is peer support in EDs. This has occurred. I know Tanya's done this through Swedish. So there's been some efforts throughout the state to improve peer inreach into EDs. And we want to continue that. And it's a high priority for CDC, for CDPHE, for the consortium. I think everybody agrees this is the ideal situation, that somebody who has an overdose or withdrawal can talk to somebody who's gone through the same. So with that, I'll hand it off to, I forgot about this slide. So funding is always something I get asked to talk about, and there is some funding. I know it doesn't feel like it sometimes, but the big one is the Rural Health Transformation Program, which I know today, this morning, the application got submitted for. If you get that newsletter, it's a lot of funds to go to improve rural health, especially around hospitals. And I know I'm like putting a happy face on that, like that is trying to offset some of the bad things that are happening around Medicaid and rural health. But those are the areas that funding will be available for. A lot of it will go to hospitals, but there will be more information early next year. So if you work in rural areas, especially around chronic disease, keep your eye out for funding from the Rural Health Transformation Program. And then something that you'll hear more at the 115 session about is that there is new-ish licensure from Medicaid and from BHA that can help improve your organization's funding. So comprehensive behavioral health providers get paid differently than other folks. And I know a lot of nonprofit providers are concerned about where funding is coming from. This is a way that you can change the way that you get paid to pay your costs. So that is a very short discussion of a very complex topic, but just know that there are things you can do to help stabilize your funding. And I'm happy to talk about them later. I'll hand it off to.
Just to clarify around the Rural Health Transformation Program, that application is going in. We don't have that money yet. When will we know? Do we know?
Think they get notified January 1st, but it'll go through state Medicaid agency, and then it will probably, they've been stakeholdering, and there will be another stakeholder input session before the end of the year. I understand. Yeah.
Thank you. With that, Jennifer, would you like to chime in on opportunities as well as things coming down the pike and successes?
Sure. You ready? Okay. Well, hello, everybody. I'm Jennifer Holcomb. I'm the Behavioral Health Benefits Manager at Medicaid. I have been with Medicaid for the last 4 years, and I'm excited to be here today. I joined Medicaid specifically working in the SED space, although now I'm overseeing the broader benefits that we cover in behavioral health. So I am excited to be here, and I really do like talking about some of the work that we've been able to bring forward, both working actually with JK and doing a lot of work with Ryan to try to make some progress in this space. So can we go? Sure.
Technical difficulties. Okay, so we're uploading slides. Should we just, the show goes on kind of thing? Okay. Yeah, I don't have slides either.
Oh, you don't?
We're slackers. That's how that goes.
It's fine.
All right. Hi, everyone. Ryan Mueller, State Opioid Treatment Authority and Associate Director of Controlled Substance Licensing at the Behavioral Health Administration. And I'm going to talk about some change. And for me, context is really helpful. So I don't think I'm exaggerating when I say that we've gone through a seismic shift in the way we consider and treat opioid use disorder in our state over the last 5 years, in particular with pharmacology. And these aren't little changes. These are all the way up to the philosophical construct of what is a patient? What rights do they have to their medication? Into operational changes like, well, how much medication should they have and where can they get it and how often can they get it? And the result of these changes have had, they've been pretty enormous in our state over the last couple of years, and I'm going to talk a bit about that. But a little bit more storytelling first. Regulations are important. We're going to talk about some BHA stuff, but it's important to say that we see ourselves at the BHA as part of this story, but not the main character. It is a community story. And sure, regulation might help to pave a road or help in some ways direct that road where it's going to go. But you gotta pay for the road. You have to have state funders to do that. You have to have people fighting for grant dollars effectively to put in those spots to treat people. Then you have to have cars on the road. So you see where this analogy is going. Just bear with me. The cars are treatment providers, and in our state, they are really nimble, and they are working to build best contemporary practice, working with new regulations, working in a complicated funding environment to deliver care that in some ways that they've never delivered before. And who are in those cars? The most important people, that's the patients, people receiving services. And for them, that takes a lot of trust and a lot of courage to enroll into treatments, especially when the treatment system has not always, let's be honest, has not always been built for them. Interview patients and you'll hear that it's not always been a happy story about receiving medication over the last 50 years. And then ultimately, overall, you have the community that supports this road and the cars and the patients that are in those cars. So that being said, that's the context for you. Going on back to BHA and what we've done over the past 5 years, on the regulatory side, we've made some significant changes, especially in the OTP rule section, about 80 changes to be more exact. But I think maybe 2 or 3 of the most significant changes to share with you today involve the ability to take out medication. For the longest time, an OTP landscape, as you all probably know, you go very often. You go very often, sometimes daily. And in the new rules, allowing not just for more take-homes, more ability to self-administer methadone at home, but it's also sort of the understanding of what that medication is. Before, can I get a raise of hands? Who has ever worked near or in a methadone clinic in this room? Oh, wow, more than I realized. Okay, so you probably are familiar with the word privilege. Is that fair to say? I'm getting a lot of head nods. Okay, so we attach that word to medication. We say it is a privilege for you to get medication to take home with you. And to earn that privilege, you've got to do things. You've got to jump through some hoops, a lot of regulatory requirements. You got to check those boxes, some of which, by the way, have nothing to do with the safety of that medication. That's how it's been for a long time, and it works for some people to have that structure. But when you lose some of those ability to check those boxes, again, sometimes they have nothing to do with safety of medication, you lose access to medication. And for some people, that's a very highly destabilizing moment in treatment and can lead to treatment disruption or treatment dropout. Fast forward to today, in the rules, it's not just that we provide more medication, but we say medication is a right. Medication is a right, and there is a science behind giving this medication, and that's a decision to be made between a provider, the patients, and the clinic to determine how much medication is safe for a person and safe for the community, kind of full stop. Then on top of that, you attach behavioral health services. So I just want to make that distinction very clear. That change has occurred sort of in flexibility over the last couple of years, informally in rule in 2025 in the summer. 2 more changes that we made. Oh, woo! Thanks, Brooke. I'll look to you for confidence now. 2 more changes that are important to make mention. We now consider and have validated through rule the use of mobile and medication units. I think y'all, in your imagination, what's a mobile methadone clinic? You're right. Whatever you're thinking it's correct. So let's go to the medication unit. That's a really interesting concept. In a methadone clinic, it offers really robust services. You have providers, you have nurses, you have peers, you have counselors offering a wide variety of behavioral health services, administrators. It's kind of an expensive operation from a staffing perspective. And that's part of the reason you see methadone clinics operating in urban settings and more densely populated suburban settings, not too much in the rural. But the medication unit is sort of an extender clinic that says you can do less service farther out. So drive 100 miles east, drive 100 miles west, put a nurse in a counter with a safe and dispense methadone. Well, now suddenly you don't need that large census that drives your larger census in your clinic to be able to keep the lights on. And as a result of that, we are starting to see proliferation of medication units across our state, which is really cool. And I would be remiss if I didn't mention the funding side of BHA, who does a lot of this amazing work too to back it up. Our SOR team and statewide programs, they have helped to fund mobile clinics, they've helped to fund medication units, and they are continuing to fund naloxone saturation and also indigent funding to support afford to otherwise get into service. So hats off to them. I think y'all are in the back. Nice work. Okay. So as a result of these things, and again, we are a part of the story, but it takes the providers, it takes insurers, it takes people that are supporting these networks and the community to come along for the ride. And what we are seeing over the last 5 years is a significant increase in treatment retention from individuals in care and a census boost. And also OTPs, now they were 25 OTPs, I think 5 years ago. We are now up to 50. We have covered 30% more counties in our state in that time and have increased our census by 40 to 45%. Which is pretty remarkable. And the last thing I'll say to that is when we see that overdose deaths are beginning to decline significantly, there's a lot of reasons for that. But what we do know certainly is that access to medication, access to naloxone, but access to medication treatment is one of the reasons that those overdose deaths are declining. So hats off to our community for doing that.
I am back, and I do have some slides to talk through some of the ways that we've partnered. I think in listening to JK and Ryan, they've highlighted some of the ways that Medicaid has really worked very hard to be a good partner. And I would like to ask folks online, feel free to raise your hand, folks in the room, how many folks participating today serve individuals that have Medicaid? Okay, there's a lot of hands here. So we do recognize that Medicaid is one of the payers and certainly not the only payer of services, but we also recognize, as if you looked around the room, the number of hands raised, the impact that Medicaid funding has to the individuals that you're working to serve. So we have worked really hard efforts where we can. To that end, I would like to highlight and talk through some of our 1115 waiver work for you. I promise these are dense slides, but they are intended for you to be able to refer back to later. I will not talk through them in detail. The first demonstration that we are in our 5th year of right now is our SUD demonstration. And that's really where we're going to focus and talk a bit today. I do also want to highlight that over the last year, a big accomplishment for behavioral health and Medicaid has been adding a health-related social needs demonstration that went live in July, a serious mental illness and serious emotional disturbance demonstration that went live in October, and a criminal justice reentry services demonstration that is planned to go live in January for Department of Corrections and Department of Youth facilities, and will then roll out the following January for jails. Next slide, please. Within our SUD demonstration, we have seen over the last 5 years a bunch of information and a lot of data, and some of it's really good and promising. Some of it is more concerning. We've used red and green to indicate the promising results. We have seen increased use of high-intensity services. We are very excited that last year we were able to add partial hospitalization as a covered benefit to keep people in the communities. We also have seen the decrease in overdose deaths. We also have seen increased coverage of opioid treatment programs. And as Ryan was talking about, the med units, we are very excited that we are able to put the pathway to ensure funding for med units in the exact same way that we fund OTPs. That's really exciting for expanding these services statewide. On the other side, the data shows us that we have continued areas of concern, and JK highlighted some of this in talking about the number of people that show up in EDs and then don't continue into treatment. So one of our biggest concerns is seeing withdrawal management as something that is cyclical. People that come to withdrawal management treatment are higher than we'd like to see repeat visitors within a 3-month period. We would really like to see better community engagement to see less return to that same level of care within a 3-month period. We also really continue to struggle as a state with youth services. And it was very interesting in the prior presentation to see some of that data around youth substance use. So that's another opportunity that remains for us. I want to talk a little about the criminal justice reentry program getting ready to launch, because there's a lot of intersection in medication-assisted treatment in this space. Historically, according to how Medicaid rule works, Medicaid can only pay for people that are in a carceral setting to receive coverage if they are hospitalized for 24 hours or longer. This demonstration allows us the ability to do something novel and unique, which is to in-reach, which is why it's reentry, and work with individuals before they are released from that carceral setting to ensure that their needs have been evaluated, that connections have been made to community resources, and that they can leave that carceral setting with a supply of medications, MAT, and any other health medications that they are leaving with a 30-day supply and appointments in place to support better transition and reentry to the community. Okay. Our timeline. We received approval in January of 2025. We are going live with Department of Corrections and DYS facilities this January, jails next January. Next slide. MAT. So we recognize the importance, as I was highlighting, of both connecting individuals that need MAT while they are in that carceral setting and connecting them to maintain that treatment upon discharge when they are integrating back into the community. We recognize the importance of this being a collaborative effort between community providers, the providers in those jails, in those prisons, in those DYS facilities, and Medicaid is working to bring all of those partners together as we work on rolling out this new demonstration. Next slide, please. This is really just an update of the approvals that we have in place. One of the requirements of this particular demonstration is that we identify any state dollars that are saved by creating efficiencies and by increased federal match that we receive by doing this work. And when we identify those dollars, that we have a publicly posted plan, which is what is awaiting final sign off of what that plan is, for how those dollars that are saved are reinvested to serve the same population. So the really exciting part about this is any dollars that we identify that we save in the state or that we bring in through federal match will be used to serve individuals in a carceral setting going forward. So that's one of the reasons that this is an exciting demonstration. Next slide. My final point, BHA and HICPF, we really do need to work hand in hand, and I really appreciate Ryan being able to bring forward changes and plans coming forward in rule, because it does allow an opportunity for HICPF to then figure out how we can support and fund. And at the end of the day, this really kind of is the partnership that we need to benefit everyone. Thank you.
I think I got it.
Okay, good. Hello, everyone. Last but not least, my name is Emily Zadborny. I am a pharmacist by training, and I currently serve as the CEO of the Colorado Pharmacist Society. So we are, like, as many of you are probably part of a professional association, we represent our members and how they take care of patients in our communities. So our members are pharmacists or technicians or licensed interns, working in all healthcare settings across the state of Colorado. So I say that because I'm going to tell you just a little story about how pharmacies and pharmacists are going to hopefully start making an impact in a more meaningful way in the treatment of OUD. And the story goes back a couple of years, 2023. The Opioid Interim Committee at that time approached CPS, our organization, and also the consortium and said, how can pharmacists help in this space? How can you help with the treatment of OUD and make a bigger impact? And so the long and short of that was myself, along with Rob and Jose and the consortium, a good collaboration, presented to that OPM interim committee for the treatment bill about a new model of care that could be considered for Colorado, and also a trusted, provider in those communities. A lot of times patients only know their pharmacist in that local community. So we said, let's look at this model. And in the end, we did get approved to go into House Bill 1045, and that ended up passing. But the provisions that were in that bill were, one, allow pharmacists to be able to prescribe controlled substances and therefore develop a protocol around that. Two was to ensure that it was a sustainable type of service. So unlike other types of providers, pharmacists are not always recognized as in Part B of our Medicare system. So we have to always ask for equal pay for services rendered. So weeds, I can always talk weeds with someone if you want, but we had to get payment for those services, just like you would pay anyone else. And three, expand the MAT expansion project so that we could potentially be eligible for some funding to get these set up. So the bill passed. We were very excited about that. And that passed in 2024. That initiated the process of us working in a collaborative way with many entities across the state, the consortium, COSAM, the physician groups, the nursing board, the medical board, the pharmacy board, to develop a protocol for pharmacists to be able to do MOUD in community settings. So that took the better part of another year, but proud to say that process worked well. And Appendix G, which is available on the State Board of Pharmacy rules, is in effect and went into effect late last year. So then, as many of you know, when you do advocacy or change policies, the real rubber hits the road when you try to implement things. So it's been a process of now gaining interest of what pharmacies will want to do this. It took a lot of effort for us to get the DEA to actually let us get DEA licenses. We got our first one in Colorado in the last couple of months. So that's a big thing. Yeah, it's really good news. We had to get like national influence involved, Congress, everything. It's, the DEA was lagging behind. I don't know if you've heard the federal government is not functioning as it may have in the past. So it took a little time to get that going. But so we have pharmacies that are getting to that point where they're up and ready. And then the most exciting recent development is that there is funding through the MAT expansion project. That RFP is now open for pharmacies to apply to help get them stood up, get them trained, and get them ready to provide these services. The protocol itself is exciting. It really is a collaborative process. So pharmacists will be working with collaborating physicians and entities in their communities, but they will be able to be that boots on the ground. If someone needs to be initiated quickly, they will be sites of care that can happen. So we are very excited that we can, start to serve in a meaningful way in this area. We're hoping that, especially with the consortium's help and the funding, that we'll find those exact areas of need that are highest and get those services going in those areas within hopefully the next, several months to year. So happy to answer any questions, but we're real excited about this.
Thank you. And I like to follow up before we get to some questions online and in the room. I try to take advantage of any time I get the microphone to talk about substance use disorder as a biopsychosocial disorder. And even though, admittedly, being raised as a behavioral health clinician, being raised, trained, and practicing in a real psycho space, it was not always communicated well how to address the bio and the social. And so while we're really talking a lot up here how to access the biological tools and resources for folks to engage in the psycho, improve their social determinants of health. And so I just want to always give credence to, don't forget the hyphen when we look at medication-assisted treatment. But I just am so grateful because I've seen it, and I know many of you in the room have seen the improvements for folks who have those medication tools to engage in treatment in an effective way to improve their social determinants of health. And so that's why one of the reasons why we at the consortium have such an interest in integrating this more, eliminating those silos, so that way every treatment space, it really functions like an OTP where you've got the menu. You can get the bio, the psycho, the social. You can get it paid for. You can go to your pharmacy. We want to open all the doors and make sure that there is no wrong door to access the treatment that folks need and the treatment that folks want when they want it. So thank you all for your efforts to continue to make this happen in Colorado. So open up for online questions for panelists, and in the room, we'll do online first if we've got one. Nope. Okay. Go for it, Hillary.
Jennifer, that was a perfect introduction to what I wanted to say. I'm Allison Gottsman, and our work is with ambulatory care clinics. And what we try to do is the bio, psycho, and social. And my question for both JK and Emily is where can we go to find a list of these community collaborative partners? Because we have a network of ambulatory care providers, both primary care and behavioral health, who are adopting MOUD, and our mantra is primary care particularly should be as comfortable treating opioid use disorder as they are cardiovascular disease, diabetes, et cetera. And that's how our program is structured. But they will benefit from community partners to be able to support their patients. So I would love to know where we can go to find out who are the pharmacies that are ready, and JK, who are the EDs that are ready, so that we can do some of that connection to the community providers that we have supported all across the state. And thank you. We're delighted to have this expanding and support the ambulatory care people who are getting involved, but it takes a community, it takes a village. Thank you.
Thank you for your question. And it actually hits me right here because, pharmacies are starting to offer more services in general, PrEP and PEP, oral contraception, a lot of public health needs. And we struggle with that very issue because we're trying to get it to be such a consistent service that we don't want someone to show up, like you said, and say, I need this service, but it's not provided here. So it's a big issue for us in general. But I think in this space, I would think some really key partners will help us with that. And I'm looking at these guys nodding their heads. Thank goodness they're nodding their heads. But I think that the consortium would be a place we can house that information once it's stood up and running. And we also very much have close partnerships with the public health department and the local public health agencies. So I think once we get these up and going, which they're not yet, so I don't have any to point you towards now, but I think those would be the main avenues that we would do that, not through the pharmacies specifically, although I'm sure they will, advertise that or have information about that. I think for the purposes of what you're saying, it'll be through these avenues where you would look to see those sites.
It's really cool to see pharmacists do more. Like I was talking to my pharmacist at Safeway, and she said she was the biggest prescriber in the country of oral contraceptive pills. I have no evidence whether that's true or not, but I was like, wow, way to go. So in response to your question, EDs, I don't know of any ED in the state that doesn't do MOED personally. There may be, but we have not found them yet. So I would encourage them to reach out they know who their ED is, especially in a rural area. I will say EDs are not monoliths. Like there are different people that fill different roles, obviously, and getting to the right person can be difficult, especially in bigger systems. But probably chief nursing officer, chief medical officer would be the best place for them to plug in and present themselves as a referral resource in the community. Do we have a referral list? So we individualized it for every hospital, did like a little GPS, but we could put it all together. Yeah, and actually some people have asked for like a map of all the MOUD providers, which on the OTP side is really easy. On the OBOT side is actually really hard because there's no X-waiver anymore. So like there's no registration for people to prescribe buprenorphine. And I also like, there's a qualitative difference between somebody who prescribes twice a year and somebody who prescribes like 10 times a day. And it's hard to make a fair map that I would also feel good about sending my mother to, because that's like my standard for referral is it's a place I would send somebody. So anyway, there's some difficulties. We are thinking about it, but I can send you any sheet we have, like happy to send you a list of, especially if you want to you're in Adams County. So yeah, we worked with a couple facilities in Brighton and I'm sure some other hospital in Adams County, and I can send those to you.
We've got one here in the front, and then we'll go back to you, Jessica.
Hello. Oh, good, it works. My name is Elise Tohar, and I'm the medical director in Colorado for Community Medical Services and Opioid Treatment Program. And I just want to start by echoing something that Dr. Costello said at the beginning, which was about how different medications will work for different people. And we know that from an evidence-based perspective. So the questions that I'm going to ask are kind of focused on when we talk about MOUD and we talk about MAT, sometimes I don't know if we're talking about one modality or if we're actually talking about all the treatment options. So I was really excited to hear a little more about the criminal justice reentry services. That is so exciting. So thank you. So from a coverage perspective, will that be covering both methadone and buprenorphine and naltrexone, or is that a particular modality?
We cover all drugs for all SUD diagnoses.
That's amazing. Thank you. Similarly, so exciting to hear about the Colorado pharmacists. My husband works at a pharmacy school at Regis. So anyway, but I always love to hear about the expansion there. And so I'm curious if the expansion of options and access for patients across the state will include methadone or if that's specifically buprenorphine naltrexone.
Yeah, that's really cool. Who's your husband?
Daniel Burlow.
Oh, he speaks at our meetings. We love him. Okay, well, anyway, small world. So that was carved out for us. So at this point in time, the law only allows us to be eligible to prescribe C3s through C5s and does not speak to methadone. That was part of the negotiations through the bill process. And right now, even at a federal level, that's not something we can do. So yeah, it's 3 through 5 at this point.
Thank you so much.
Hello, Katie Sullivan. I am the prescription drug epidemiologist at CDPHE. I work with the prescription drug monitoring data. And before I ask my question, I just want to say this is very cool. It's really great to hear from all of you. And also wanted to say hi to Rob because he was my dissertation advisor when I was just a wee student. And it was like my second year of grad school when the consortium got started. So I was sort of like shadowing him through all of it. So this is really amazing. I really just wanted to mention that right now we are working with a COAG-sponsored project with the DOC on continuing buprenorphine after they've been reintegrated and looking at sort of post-release how they're continuing those medications and various metrics surrounding that. So it'll be really interesting, and I would love to connect with you, Jennifer, on that, and to see how maybe those numbers and metrics shift and change as coverage continues, and this has become kind of a focus. So not as much a question, but just kind of wanted to put that out there and share that. So thank you.
Yeah, that's fantastic in those slides. Contact information's out there. Would love to hear about what you've been seeing, because that's very informative baseline information for us to know too as we move forward. Thank you.
One last question, I
Is
think.
this on?
Yep. Or we've got two. Okay, two questions.
I just wanted to raise a concern and see if there's a response. We heard from the data science people that most of the overdose deaths are in urban areas, and it's only 10% that are coming from rural areas. And I'm hearing about this huge grant opportunity for rural hospitals, and I'm wondering about the hospitals in the urban areas where 90% of the doses are happening. What does it say for them and their ability to respond to this crisis? And with transitioning people on buprenorphine or Don Sater's direct inject idea of intramuscular buprenorphine, things like that. Will there be no money left for the urban hospitals?
Is that me?
I don't know.
Well, so the Rural Health Transformation Program, slightly different. It's not really substance use specific, but understand your concern. So the idea was that rural hospitals are more likely to be independently owned and have a much higher failure rate than urban hospitals. Colorado's been super lucky in that we have not had a single rural hospital go under. Other states are definitely in a very different situation where they experience this like every few months. Rural hospital gets shut down. And I wouldn't say that could never happen here, obviously, but it's a particular interest because they are more likely to be out on their own and not under the protectorate, affiliated with a larger health system. So like just yesterday, there's an article about Estes Park Health may merge with UC Health. And obviously that gives them like some sustainability because UC Health has, I think they've got some money in their bank accounts. And so Estes Park, we'll have them on board, but there's other health systems like Memorial Regional Health and Craig, they have nobody who's going to save them. And so this fund, given that Medicaid is plans that the federal government are to reduce Medicaid, like inexorably over the next few years, that was the rationale behind this at the federal level. And so that's why it's directed at rural hospitals and health centers.
So can I add with regard to this is a Medicaid grant, part of the intention, everything that JK outlined, completely agree with. And I would add, I think this is the big opportunity that we are trying to highlight is integrating care across the continuum and integrating care, not just reaching the level of being provided in a hospital setting, in an ED setting, but having those community connections to have strong communities of care throughout the state. And a large part of the Rural Health Initiative is about building those hubs, if you will, of services in those spaces. Your points about what's happening in the urban setting are really important points, but it's a slightly different challenge in the urban setting. And in the urban setting, it is less a matter of availability for the hospitals to avoid failure and more of an opportunity to increase and strengthen those connections for transitions of care and have more robust community supports to pair with the hospitals?
Hi, I'm Suki. I am an addiction med provider at Children's Hospital Colorado. I appreciate you all. I was wondering if there's any specific work that's youth focused, and just to kind of pivot off of what you just said, like there are very limited resources in the community for youth, just beyond residential treatment. I think there's a difficulty in finding providers who are comfortable with MAT, especially MOUD. Is there any work from the pharmacist side to provide or provision some of these services? And even in the emergency departments and children's institutions, there's a real reluctance to treat addiction, especially opioid use disorder. I was just wondering if you could all speak to that and the work that's being done to address like this huge disparity in care.
Well, I can start because you asked. Unfortunately, the protocol that exists for us that I just spoke about is 18 plus. And that was something that was decided upon by all the stakeholders and probably appropriate for this type of, protocol. However, I think there's always an opportunity to explore collaborative types of agreements that are outside. This is the statewide protocol, but our providers can enter into any type of, agreements or agreements really to do this type of work for any patient population if that's something that, systems want to partner with pharmacists or pharmacies to do. That can be done outside of this. But for the purposes of this established protocol, we're 18 plus.
May I add to that? What an important point. I don't have a lot of great answers, but on the regulation side, we have taken strides to help reduce barriers and reduce stigma. We've had some archaic rules that have been around for a long time, specifically around youth. Things like you have to show 2 episodes of treatment failure in order to be considered. And that would sort of scare providers off, and they get the hint like, got it, we're not really supposed to be treating youth in this space. And there's also societal stigma, not my child, and this really significant barrier between MOUD and anyone under the age of 18. So we have changed those rules recently. They just went live in July to support providers, methadone providers, who also support with Vivitrol and buprenorphine to treat those populations. But I have to say it's been a slow uptake.
And I just like to wrap us up by saying, if you all haven't met Suki here, take advantage of doing so during the lunch, because I envision, my crystal ball says next year, Suki's going to be up here talking about the mountains that she has moved to create avenues for youth to get access to treatment. So that's one of our goals for the next year, is to help move that forward and address that evident disparity. So thank you for that. We're going to thank our panel.